Thank you.
So I welcome all the participants that have joined today to the second session in a series of talks that the Research Committee of IPS West Zone has arranged. And all these talks are very pertinent, given by experts on various aspects of how to plan and conduct research in psychiatry. And I welcome all of you to the second part. And there are 6 more to come. There are total 7 talks. So 5 more to come on each Wednesday, third Wednesday of the month. And now I welcome Dr. Neena Sawant ma'am, our president of IPS West Zone, to give the welcome address.
Thank you, Pooja, and a very warm welcome to all the members who've joined here today for another interesting session. Most of us as residents have done research methodology workshops, and probably we have had one lecture on sampling, sample size calculation and how to go about it. But we are as, what shall I say, as aware of sampling methods as today, where, maybe we use that formula to calculate, but many times we also don't know whether we are doing it right or no. So who better than an expert in the field who will at least tell us basics. We all would require plain basics, Dr. Patil, from you, so that the zone is now, the zone has started giving research projects and trying to do collaborative research in the zone. So these sessions, which are organized by our research subcommittee, definitely will be of use for all the members who are also planning to apply for these research grants. So I welcome our speaker and I welcome our chair, Dr. Mehta here, and I hand over to Saili for the further proceedings.
Thank you, ma'am. Thank you very much. Good evening, everyone. I am Dr. Saili Dabirao. I work as an assistant professor in telemanagement unit here at AIIMS Nagpur. It is my pleasure to introduce our chairperson today, Dr. Ritambara Mehta ma'am. Ma'am is a professor and head of Department of Psychiatry at GMC Surat. She has also worked as a dean at GMC Surat and Hospital. Under her leadership, the hospital and college has successfully managed the worst phase of COVID-19 during the years 2020 to 2023. Ma'am brings extensive experience in the field of psychiatry with her knowledge accumulated over 30 years of her dedicated work. She has trained around more than 100 psychiatrists as a professor who themselves are now spread across the country and abroad. Ma'am herself has 60 plus research publications on her name. We welcome you, ma'am. Thank you for chairing the session today. I would like to request Mehta ma'am to kindly introduce our speaker today, Dr. Deepak Patil sir. Oh, over to you, ma'am. Thank you.
Yes. Thank you all, especially the West Zone branch president, Dr. Neena Sawant. I remember, madam, when you came as examiner, we also had one session on how to write a research paper, and it was a very interesting session. And somehow it's a coincidence that I am given this responsibility of chairing the IPS subcommittee of research grants. So I again urge, as madam said, that as West Zone, you all do write a good research proposal and apply for that. Very soon the instructions and directions will be out from IPS also, and West Zone also has been inviting the research grant. So that's wonderful, and it's very apt, the topic which is chosen by the president and all the other subcommittee members. And especially in psychiatry, what I can say is research poses some unique situations, a little different from other medical branches. As madam said, sample size, sometimes it's very, very, what should I say, when we go for the sampling, we think of those formulas and all, but sometimes with qualitative research and all, we don't have to apply such sample size formulas. Our patient population is very unique, very vulnerable, and sometimes capacity and comprehension are also compromised of our patients. So in that case, informed consent, etc., a lot many unique questions, can be, and situations can be there in psychiatry research. So definitely, it's a very interesting topic, and I am very happy to see the young people coming forward. Especially, I have to introduce Dr. Deepak Patil. I welcome him for this forum. He is an associate professor at Department of Community Medicine at KG Somaiya Medical College, Mumbai. And he has been an approved faculty for research methodology by MUHS since 2015. He has been conducting so many research methodology workshops in colleges, and he has a vast research experience. He has been trained in data analysis, especially using SPSS, Epidata, and QGIS software. As psychiatrists, sir, we can always say that statistics is so volatile for us. We do it for one research and we forget, and again we have to learn and relearn and relearn. And many times here also we actually approach all the community medicine professors for these statistical help and things like that. So your experiences will be very, very beneficial for us. Thank you, sir, for getting our invitation and accepting it. Over to you, Sally, and we'll listen to Dr. Deepak Patil.
Thank you, ma'am. I request Dr. Deepak Patil, sir, to kindly start the session for today. Thank you, sir. Over to you.
Very grateful to Mehta ma'am for this warm welcome, and also Neena ma'am as well as Saili ma'am for giving me this opportunity to present. As already madam said, it's mostly volatile, and I always say this, that you are psychiatrist and you be the psychiatrist. But we need to understand where we can use statistics and how to conclude the results coming out of statistics. The in-between process is dealt by most of the time softwares. We may or may not have to master them, but what information need to be fed and how to interpret the results, that much we should be aware of. So with that background, I would like to make this session more interactive. May I just know the topic of previous month's topic? What was the topic for the previous month?
Yeah. So what happened is we have just started the series. This is the second of the talk of the series. The last month, what we had discussed is writing a case report and letters to the editor. So I can really say this is the first core statistical or research methodology wise topic for us.
So good for me. This session will be based on certain basic study designs, and if possible, we'll try to cover as much as sample size calculation we can do in this small interaction. So I would like to present my screen so that all of us can. Is it visible?
Yes, sir. Yes, it's visible.
Yes.
So let's see a few research questions. Most of you must have done research, and we have some very senior faculties who are very much knowledgeable about research. So if this is a research question, what is the proportion of postpartum psychosis among mothers delivered in a tertiary hospital? So how this would be conducted? To whom we should be approaching and what information we should be collecting? Anyone? Sorry, I have to make it interactive, otherwise it will sound very boring. Please, anyone?
So we'll have to screen all the females who have just delivered in a tertiary hospital. And sir, more of cross-sectional study we would like to do. We like to assess the risk factors and the risk factors which can lead to postpartum psychosis, and the basic socio-demographic and clinical details after assessing that the patient has postpartum psychosis. And we exclude those females who are like acutely sick or yes sir, yes, that's it, sir.
Thank you so much, Mohita, madam. Sorry, I don't know the designation, so I'll call everybody madam for that matter. Uh, so basically, the outcome variable in this research question is postpartum psychosis. And as she rightly said, there are multiple things we would like to collect the information about, including clinical profile, maybe other psychiatric comorbidities, and maybe other family history details, and maybe even a quantitative measurable variables like hemoglobin status, blood pressure, etc. But primarily, the outcome variable for this research question is how many of these women had postpartum psychosis. So based on your inclusion exclusion criteria, you will enroll all the women in your study duration who delivered in that particular tertiary hospital, and you will assess them for postpartum psychosis. And as per your DSM-5 criteria, you might get few of them having postpartum psychosis as a diagnosis. So let's say this study being conducted by someone, and this is what the result came out. So suppose 100 postpartum mothers are enrolled during the study duration, and 10 out of them had postpartum psychosis as per DSM-5. Then the proportion of postpartum psychosis will be 10%. I know this is not the realistic proportion. Just for simple math, I kept it likewise. So if I have to see what is this basic study design, as already Mohita madam has told us, cross-sectional. So now we need to follow this chart and tell me where does it exactly fit in and what should I be calling this study design. Is there any intervention in this study?
No, sir.
No intervention. So it becomes an observational study. Okay. Then is there a comparison group to begin with in the research question itself? You want me to show the research question again? Am I audible?
Yes, sir.
Yes, Dr. Patil, you are audible.
I'm saying, is there any
Some people are trying to type it in the chat box. So I think, Saili, would you read out the options that are people giving in the chat box?
Yes, sir.
Yeah.
Raj has replied to your question, sir, saying no. And one anonymous attendee has replied also no.
Demonstrate one, right?
It is.
I'll demonstrate one right now. So there is no comparison group in the research question stated as such. So we'll go to this side of this flow diagram, and you can see what is written is descriptive study. So to be precise, this is a descriptive cross-sectional study. So if you have to write this design, the actual term should be descriptive cross-sectional study. That's the complete term. You already seen case studies and case series study. Those are also having no comparison groups, and they also fall under observational studies. Okay. So let's move on to the next research question. How this study will be conducted. What is the outcome variable here again? I've selected the single outcome variable for all the research question, and that is postpartum psychosis in this research question again. But here the researcher want to compare. So there is a comparison group, and the groups are one group who underwent C-sections and another group who delivered by full-term normal delivery. So somebody did this study, so they will have to have two groups enrolled since the beginning of the study based on their inclusion-exclusion criteria. So suppose somebody did this study, so they have enrolled 50 pregnant women who have undergone C-section and 50 pregnant women who have undergone full-term normal delivery, and 10 in the C-section, while 5 in the full-term normal delivery group developed postpartum psychosis based on the DSM-5 criterion. Then obviously the difference between the postpartum psychosis between these two groups is 10%. That's a simple math. Now, where does it fit in this flowchart? Is there an intervention again? No. Is there a comparison group in the research question itself?
Yes.
Yes. So that becomes an analytical study.
Analytical.
And what was the outcome here? Postpartum psychosis. But what was the exposure? Is there an exposure in this research question?
No.
That C-section and FTND itself is the exposure actually. And this exposure as well as the outcome has occurred in a same time zone, and that's why this fits into analytical cross-sectional study, this particular type. So cross-sectional study itself has two different types. The earlier one you saw was a descriptive cross-sectional study. The second one you saw is an analytical cross-sectional study. The difference is the researcher began with two groups at the beginning itself, and he compared the postpartum psychosis between those two groups. And that's why the research question stated difference between the proportion of postpartum psychosis between those two groups. Am I clear about these two differences, two studies design differences, or somebody have any question?
No, you're clear. You're clear.
Okay. So I'll move ahead
Sorry,
with the next.
sir, 1 second, sir.
Yeah, please. Can I take
Sir,
it now or should I take it later?
Yeah.
sir, can I ask right now or later, sir?
I don't know. I mean, when should I take the queries? Yeah, please, Raj. Go ahead.
Sir, exposure then is defined as that whatever is the full-term normal delivery and C-section, both of them are the exposures. That means the
Yes.
predisposing factors are known as the exposure, sir.
Yes.
Okay,
Yes,
okay.
exposures. Those groups itself are exposure, although
Yes,
they are
sir.
not the classical exposure like smoking and lung cancer, but they will be considered as an exposure variable here.
Okay, thank you, sir.
It could be like in this case, male female is not possible, but it could be any basic demographic variable, upper socioeconomic class, lower socioeconomic class, something like that, or having family history of psychiatric illness, not having family history of psychiatric illness, something like that as well. But the information is collected during the study itself. It wasn't collected from the past as such. Let's see this particular research question. So what is the difference between proportion of PIH during ANC among cases of postpartum psychosis versus healthy postnatal controls in a tertiary hospital? So what is the exposure and what is the outcome? Yeah.
Sir, I have a doubt in previous study design, sir. Sir, I want to ask that sometimes in a cohort study, like we see the exposure at one we do retrospective thing. So, like in this thing also, like when we are doing analytical cross section, so we are asking about like when the C-section happened or the full term delivery happened, and then we are analyzing. So, like how do we differentiate it from like retrospective thing
That's what the next example is.
Yes.
So I understood your concern, but we'll hear out the next study design, this one. So here, what was the outcome variable? Again, postpartum psychosis. But now we are calling them as cases, while we are considering healthy postnatal deliveries as, or normal postnatal deliveries as controls. I mean, those women who did not develop postpartum psychosis. So one side we have cases of postpartum psychosis. Another side we have healthy, normal PNC mothers who did not develop or did not have postpartum psychosis. They are acting as controls. And now you are going back into the history and you are trying to find out whether they had PIH during their ANC period. This is a classical going backward, retrospective. Okay, so what will happen eventually? Among those cases of postpartum psychosis, you will get few or many of them had probably history of PIH, and in the other group where there is no postpartum psychosis, the number of mothers who had PIH during ANC might be less. That's what we are anticipating, considering PIH as one of the risk factor for ANC PIH, considering as one of the risk factor or exposure factor for postpartum psychosis. So somebody does this study, so they have enrolled 50 cases of postpartum psychosis. So they will start from the outcome. And similarly, they have enrolled equal number of healthy PNC mothers who did not have postpartum psychosis. And now they went back into their history, their ANC records, and they found out how many of them had PIH. So in this hypothetical example, 10 in the postpartum psychosis group had PIH, while only 5 had PIH in the other group, the control group. And that's why again the difference between the proportion of PIH between this by cases and control is 10%. So we went from the cases, that means from the outcome, to the exposure, that means PIH. Okay. And this research question can also be stated commonly like this. What is the association between PIH, that is exposure during ANC, and postpartum psychosis as outcome? And the other way to state the research question is like the difference between the proportion of PIH during ANC among cases of postpartum psychosis versus healthy postnatal controls. So we have already enrolled the outcome cases of postpartum psychosis, and then we went back into the history. And we also had a comparison group for that, which are healthy mothers who did not have postpartum psychosis. So exposure classically is occurring in the past. So this is an example of which design then? Now, do we have a comparison group? Yes. So it becomes analytical. Direction of exposure is from outcome to the exposure. That means retrospective. So this becomes a case control study design. Does it sound more relatable with the earlier research question where we just had deliveries type and we just compared their postpartum psychosis proportion? There the outcome and exposure occurred in nearly similar time span, while PIH in ANC is in a relatively past kind of record, exposure which has occurred earlier. And then we are seeing whether it is affecting the outcome. And that's why this particular design is case control study design. Now, is it more clearer if we compare with the earlier research question? Does it answer the query what you are trying to ask?
Mohita, are you there?
Yes.
Okay, no.
Yes.
You think about this again, because I'll give you two variables which you can select and you can prepare all sort of research question based on the same variables. One is exposure, one is outcome. You can select and do it. The more we do and write it, then we relate it better. And we need to also see how we are going to conduct this. That's why that study procedure is important. Just looking at the research question at times may not give us idea about study design. I'll show the example in next particular discussion now. This is the next research question. What is the difference between the incidence? Incidence means new cases of postpartum psychosis among mothers with PIH in ANC versus uneventful ANC in tertiary hospital. Now, outcome is again postpartum psychosis, and exposure is PIH during ANC. Same variables. But now, if you look at the research question, they are asking how many new cases are developing, those who have PIH versus those who have normal ANC. That incidence word is the key. That how many new cases of postpartum psychosis are developing among ANCs with PIH versus
Uh, Dr.
Sir,
Deepak, sir,
your
you are
voice
not
is
audible.
breaking.
sorry, my internet connection was unstable. Am I audible now?
Yes, sir.
Am I? So here we have to first enroll all the ANC mothers who are expecting in our tertiary healthcare setup during our study duration based on our inclusion exclusion criteria. Then we will follow them up. Few of them will develop PIH during ANC. We will not select purposefully at the beginning itself with the history of PIH. Okay. Few of them will develop that exposure on their own because of their pathophysiology during ANC. And rest will not develop, so they will fall in the other group. They may develop other complications, might be anemia or some other obstetric issues, but they will not have PIH in first place. So the two groups what we segregated based on the exposure they are developing is PIH group and non-PIH group, or uneventful ANC rather. And now we'll follow this expectant mother till their postpartum period, and we'll see how many of them are developing postpartum psychosis. So this is a follow from the exposure towards the outcome. Exposure is again PIH and outcome is postpartum psychosis. Now obviously we are trying to speculate that many mothers in the PIH group, or the number of mothers developing postpartum psychosis in PIH groups will be more as compared to those who do not have PIH. So if this study is being conducted, so 100 ANC mothers are enrolled and followed up till 6 months post delivery. Out of them, 30 developed PIH during ANC. So naturally, the 70 were in the uneventful ANC group with respect to PIH. They might have other events. On follow up, 6 out of 30 and 7 out of 70 develop postpartum psychosis. So it appears that postpartum psychosis is more in the uneventful group because it's the number is 7, but the proportion is less because it is out of 70. So again, the difference in the incidence, that means how many new cases of postpartum psychosis developed in the respective groups, is 10%. Now here we move from the exposure to the exposure variable, that is PIH, to the outcome variable, that is postpartum psychosis. Something like smoking and lung cancer. I think that is more relatable. So who smokes and who don't smoke, we don't decide. They pick up that behavior on their own. And that's a typical cohort study where you start from the exposure. In fact, when you enroll them, they do not have the exposure. They are exposed during the course of the study. They naturally get divided into two groups based on the exposure history. And then they progress towards the outcome, which is in this case is postpartum psychosis. So if you follow the same, again, the research question can be stated in the same language as we saw in the earlier case control study design. What is the association between PIH during ANC and postpartum psychosis? So here the understanding becomes difficult based on the research question, because if you check the case control study design research question, that is also stated as what is the association between PIH during ANC and postpartum psychosis. So this research question may have a study design which is either case control or cohort. And if it is stated like this, in an exact incidence kind of statement, or in the exact proportion kind of statement in case of case control design, then only it is clearer that whether it is case control or cohort. Or else we have to read the study procedure and then only we'll understand what is the study design. So even in published literature, it has found that the title means study design is allowed and procedure may it is different. And it is not being reviewed by the journals or their peer reviewers, and it is being published and accepted and being followed or referred by as it is, and in fact repeated also similar. So we need to always see the research question. If it is not giving us idea about the study design, we need to go to the procedure and see how, right from the beginning, how the subjects will be enrolled, what is done next, and then only we'll understand. That means study procedure will make us understand which study design we are following. So if you, for this particular study design, there is a comparison group based on the exposure, and the direction of exposure is from PIH to the postpartum psychosis. And since we are moving from exposure to outcome in a prospective way, this becomes a cohort study. So I have completed one arm, and I think this pace is good enough. Or should I be a little faster than this? Saili? Dr.
No,
Saili?
Yes,
ma'am?
this space is good, sir.
Okay. So I can take queries about this part right now, or I can complete the experimental research question as well, and then we can take queries about all the designs. So I'll proceed with the
Uh,
other. Yeah,
there
anybody
are
want?
some questions in the chat box, sir.
Hmm.
So how do you differentiate between retrospective case control and retrospective cohort study?
Yeah.
This is one question, if you
Only
like
thing,
to answer.
yeah, only thing is in retrospective cohort study, both the exposure and outcome has typically occurred in past itself. And most of the retrospective cohort studies, the data collection is based on the records. Okay, for example, you wanted to see this same association between PIH and postpartum psychosis. So you will go back into the record, let's say 20 years back, and then from in that, or maybe 10 years back, and in that year, you will find out all the ANCs registered at the beginning of the year or throughout the year, and then you will follow them in the record again prospectively. But technically, both exposure and outcome has occurred in the past itself. And that's why, in fact, it is just going back in history and again coming back in front to the recent history. So it is technically a retrospective cohort study. Otherwise, everything remains same. Does this answer the query?
Um, sure, sir.
So
Thank you, sir.
let's say, yeah, I'll elaborate this way. Let's say we want to study the association between PIH as an exposure and postpartum psychosis as an outcome for the year 2021. Now, both exposure and outcome for the mothers who delivered in or they were ANC during year 2021 has occurred already. So we'll enroll from the record. We'll enroll from the record those mothers who are expectant at the beginning of 2021, and then we'll follow till they deliver. And from the history of their record kept so far, we'll come to know that how many of them had PIH ka history, and within PIH, how many had postpartum psychosis, provided somebody has done this. Okay, every mother will not be screened for postpartum psychosis unless there is a national health program or there is a robust monitoring mechanism established in that institute, something like NIMANS or something. So this is possible based on the records, and this is an example of retrospective cohort for the same design, where the exposure and outcome is already occurred in 2020. Okay, does that answer the query?
I'm sure it does, sir. Thank you. There is another question. Can you help us explain a nested case control study? It is by Dr. Adarsh Singh.
Okay, so in a case control study, we have a typical outcome to exposure kind of data collection, and that is possible even in a larger cohort study. So where we have already exposure, we'll go back and find out certain exposure which we did not intend or we haven't intended at the beginning of the course study, and then we end up a small subgrouping of within that group. We made a small subgroup and we made cases and control, and we went back into the history. So this is an example of nesting the subgroup or creating a subgroup of population and doing a simple case control study. So that's an example of nested case control studies. But my query is, are these studies being done by the psychiatrist? I mean, I never read any nested case control study. I may be maybe little less knowledgeable about psychiatric research, but are these studies being done routinely or?
No, I don't think so. None of us are.
Well, I purposefully avoided those variations. I have mentioned this later. Okay, this is not being discussed in this because that will take up our most of the time, and then we will not be able to finish what we intended.
Yeah.
So I would like to address this later, maybe if you give a chance. Maybe those deviant designs. There are quasi-experimental studies. There are single group before-after studies, and there are validity of diagnostic test related studies which are a little different than what we regularly do. So maybe a different session I would be able to address it more in detail.
Sure, sir. Yes, sir.
Shall I
Thank you, sir.
answer the query or shall I?
Yes. Yes, sir. Please, sir.
So this is a next research question. What is the difference between the efficacy of interpersonal therapy and treatment as usual, that they have short form as TAU, in prevention of postpartum psychosis among expectant mothers? Actually, this is an article I came across, RCT, and they have done these two interventions. Yes, therapy is an intervention and the regular treatment is also an intervention. And they want to compare the efficacy of these two treatment modalities on prevention of postpartum psychosis. So again, the outcome in this case is postpartum psychosis, and we're expecting that in one of the groups, the number of cases of postpartum psychosis will be less. So if I have to state a research question for this in a different way, I would state it this way. What is the difference between the proportion of postpartum psychosis among ANC mother receiving this interpersonal treatment therapy and treatment as usual therapy? Okay, and when I mention receiving, that means it's become intervention. So we can compare both the research question. The same research question is stated little different way. So if I have to do this study, I have to enroll the mothers who have postpartum psychosis right at the beginning, and I have to divide them into two groups. One group will receive the IPT therapy, other group will receive the TAU therapy. And sorry, I have to enroll the mothers who are expectant. Sorry, I made a mistake. I went to the treatment arm. To enroll the mother who are expectant, and I have to purposefully enroll them in these two treatment modalities, and we'll have to follow whether they develop postpartum psychosis or not. If I have to do some drug related efficacy, then I will enroll the postpartum psychosis patients. So let's say I have enrolled 100 ANC mothers and followed them till 6 months post delivery. So this looks like to a cohort study, but it is not a cohort because here there is a deliberate intervention. So 50 each were randomly allocated into two arms. So these were normal ANC mothers at the beginning, and 50 of them allocated into the IPT arm, and another 50 were allocated into the TAU arm. That is a control arm. And then they've been followed up whether they develop postpartum psychosis or not, being outcome variable. And it is found that 5 out of 15 the IPT arm developed postpartum psychosis, while 10 out of 50 developed postpartum psychosis in TAU arm. And obviously the difference between this proportion is again 10%. So here a deliberate intervention is done, and then we are assessing the outcome in terms of prevention of postpartum psychosis. So here itself, since the intervention is assigned in terms of a treatment modality, this becomes an experimental design, and allocation of the subjects is random into the two treatment modalities, and that's why it becomes a randomized control trial. But if it is not a randomized allocation, at times it happens, especially in invasive treatment modalities, or there is no way we can randomize, there are ethical issues, then it falls under non-randomized control. So we have discussed this basic 5 designs as of now. And if there are queries, I would like to take again, or I would like to proceed with sampling with respect to 2 aspects, sample size and sampling methods.
I think for now there are no queries. I request the attendees to kindly ask the queries if at all they are there.
If I can just ask, sir, in this last example, like we have taken 100 and then you said 50 in IPT and 50 in treatment as usual. But usually if we do it like this, all do not develop this what should I say, postpartum psychosis. So once they develop out of whatever 100, but then once they develop, then we randomize sometimes that one goes to the treatment as usual and another goes to IPT. So
Yeah. Yes, ma'am.
yeah.
Okay. So this particular design or this particular study is actually done to see the prevention effect on postpartum psychosis. So they have enrolled expectant mother actually. This is actual study conducted recently. I think 2021 study. I've given the reference also. And they followed these mothers and they were expecting if we start administering this therapy as a preventive modality, as a preventive treatment, then how much it has effect on not developing postpartum psychosis. So they're
Okay,
expecting,
okay. Right. So
and
this is
actually,
a preventive measure. This is a
yes, yes,
preventive measure then. Yeah.
preventive therapy. Actually, I
Right.
began with the enrollment of postpartum psychosis patient. That's why
Right.
that. So yes, if you are having new drug treatment modality for postpartum psychosis, then what you are suggesting is the way we might
Right. Right.
conduct the RCT, where we'll
Yes.
enroll the postpartum psychosis patient and we'll give half of them one treatment, one new drug, or maybe a conventional and the other conventional treatment, and then we may follow them whether they are responding to the treatment appropriately or not. Yes, that
Right.
will be a there the study will start itself from the postpartum psychosis patient. But
Right.
this study started from the normal expectant mothers as such.
Right. Right. Yes.
So if you compare cohort and RCT, in both the cases we are following the mothers actually. In fact, in both this example, what I shared here, all were the normal ANC mothers at the beginning. But in the cohort, we were trying to associate PIH status with postpartum psychosis in the example earlier I gave. While in this experimental design, RCT, we are seeing the effect of treatment modality on prevention of postpartum psychosis. So there is only one difference between cohort and RCT in that fashion, that in RCT, the manipulation, the intervention is deliberate and done by the researcher to see the effectiveness. While in cohort, there is no manipulation, there is no deliberate intervention. We just see the association between exposure and outcome. That is the difference between cohort and RCT.
Right. That was an excellent example, I think, for both. Thank you.
Thank you, ma'am. So with this, we complete the study designs, which are the basic designs what we discussed. And I would like to move on the second part of it, that is sampling. Sampling consists of 2 broad aspects. One is sample size, another is sampling method. So these are the steps which I had mentioned here, or maybe a prerequisite you can say for sample size estimation. So we should know the study design. We should know the research question or at least the primary objective. There might be multiple objectives. There are multiple variables in our studies, and then we kind of not sure which variable to use for sample size. So I will try to answer that as well. Whichever is our variable of interest or priority variable, we should have information on that variable from the literature review, from a published literature review, which is in recent time preferably. And then we should know which sample size calculation software will help us. So this is the one which I recommend because it broadly covers most of the sample size calculation, barring few, and it is recommended by CDC. And also we should adjust for non-response rate, and we should also know how to exactly write the sample size write-up, calculation write-up in the protocol as well as in the final research paper. And yes, sampling method has to be also mentioned, preferably a random sampling in all quantitative studies is required. And a randomization method, if at all we are following RCT design. Randomization and random samplings are different. So let's take the first example, the descriptive cross-sectional study. What is the proportion of postpartum psychosis among mothers delivered in a tertiary hospital? So here the researcher enrolled the mothers who delivered in the tertiary hospitals. He had subjected all of them to the postpartum psychosis assessment, and the number of mothers who had postpartum psychosis will be counted as postpartum psychosis. So you get the proportion eventually. That is what he is intended to do. Now, this study must have been done by someone. Let's say that this study is done by one of you, and this is what the finding is. And it is also published by you. So I got the information on the variable of interest. The variable of interest is postpartum psychosis. And I got from published literature, the proportion of postpartum psychosis is 10%. Now, this has to be a similar setting, a recent study, and a good reputed journal in order to quote the reference. Now, if I go back to the steps, what I said, the study design is descriptive cross-sectional study design. The primary research question is the researcher want to find out the proportion of postpartum psychosis among the hospital deliveries, and the information on variable of interest we already have from, as one of you have conducted this research and published in a reputed journal in recent time, is as 10%. And the sample size calculation can be easily done now using this OpenAP software. So actually you can open this in the side window if possible. I would request actually if you can open, just type OpenAP. Just type OpenAP in the Google search. And if you click on OpenAP, you will get this kind of window. You can follow the link address also. Who will tell me where is the sample size calculation tab is there on this panel? Everyone got it? If you don't have a laptop, you can do it on a mobile as well. This software is need not to be downloaded or anything. It is available free of cost with all the references. So if you check this panel, there is a option of sample size. If you click on that, you have different options again. So if this is a study design which is cross-sectional and a descriptive cross-sectional, and I'm interested in finding the proportion of postpartum psychosis, which option I should select? Are you there with me?
Yes, sir, we are.
So which option I should select? There are 4 options only. This is not cohort, this is not case control, this is descriptive cross-sectional, and I'm interested in finding the proportion of postpartum psychosis among hospital deliveries. So I'll select the option of proportion. So once I click on that proportion, I get something like this window. If I click on enter new data, at the beginning only, Mehta madam said that we have very vulnerable population of patient and our studies are possible only in certain settings. Probably getting the patient itself is very difficult. So based on your hospital turnover, you can adjust this population size. Okay, suppose the number of deliveries in the hospital which I am doing the study are itself 500 in a year or in a span of 6 months, and my study duration is also 6 months. In that also data collection may be only 3 months. So based on the span, you can adjust this particular number, that how much study population might be available to you in your institute. Because as far as I know, most of the psychiatry research are institutional based. I don't think there are many, I mean, very few might be community based research like we do in our community medicine. So here is the option where you can change. Suppose the number of deliveries in my hospital are 500 during my estimated deliveries, during my study duration in which I am going to do data collection. So I just modified that population size as 500 deliveries. Now this is the second row where I have to fill in the proportion I got from the review article. As one of you did the study and you published in recent journal, and the proportion of postpartum psychosis was found to be 10% in hospital deliveries. So I'm putting this 10% over here. This is the anticipated proportion from a published literature. I'm using this. It has to be from a published literature or at least a textbook. And if it is a novel study, then only you can assume based on the WHO reference. Now, this is one more thing which we need to decide as a researcher how much value I should take. So this is called as absolute precision, or in other words called as confidence limit. The simple thumb rule is it should be always less than your proportion value. So here the proportion value I've taken 10 and this is by default 5, so I'm not changing it. So it has to be it should be less than 10, that less than the proportion value. If this proportion would have been 50, I could have increased this. Again, the upper limit to increase is 20. I can't go beyond that. That is the only rule. So either it has to be less than the proportion or it has to be less than 20. Either of it has to be satisfied. And this particular section we only follow or use when there is a cluster kind of sampling. So we don't do cluster sampling in most of our researchers. Those are large community-based studies. So we need not to change anything over there. So I changed this 500 because the hospital turnover of deliveries possible during my study duration is only 500 maximum. So I changed it to 500. I took this as a 10% because from a published literature done by you, I got this reference that in hospital deliveries in similar setting in recent time, the proportion of postpartum psychosis is 10%. So I'm using it. I'm quoting that reference also when I make the write-up. And I did this absolute precision. The only rule is it has to be less than P, that means less than 10 in this case, or it has to be less than 20. If the P, that proportion is more than 20, then it has to be less than 20. That is the only rule. Because if you exceed this more than 20, then your power of study is not 80, it is lesser than. You have heard this terminology somewhere sometime back. So when I fix this to less than 20, the power of study is more than 80 always. So now I just need to click on calculate and you can see this first row that at confidence level of 95%, the sample size is 109. So how many mothers, how many deliveries from the hospital I have to screen for postpartum psychosis? 109. Here is the formula. As I said, you don't have to break your head on that, but all the details are also there. This can be copy pasted, this can be saved, and this can be also given as it is in the write-up, but we prefer to do the write-up little different because university has certain rule or certain journals have certain rule how to write the sample size write-up. So just a click away, you can calculate a sample size, and this 95% confidence level means you have fixed the p-value to 0.05. That means the result will be statistically significant only if the p-value is less than 0.0. Also, if you want to understand this in more detail, so you have to click on the help section and the step-by-step elaboration of each step is done in this help section for each of the options. So even if you stuck somewhere, you can always refer the help section and follow that particular step. So in this study, if I want to conduct using the reference what I followed, I need to enroll 109 hospital deliveries and screen them for postpartum psychosis. And I may not get 10% postpartum psychosis in my study. It may be different than that. But that will be the finding of my study. And then I'll be publishing it, and somebody might be using this as a reference for their sample size calculation. That's how it goes. So if I have to write the write-up of this particular sample size calculation, I haven't added non-response rate, but if it is 109 sample size, the non-response rate, if I take 10%, that 10% of patient may not allow me to use the data even if they're eligible, even if they give the consent and later on they drop out in some unwanted circumstances, then 109 ka 10% I will add, and that will become around 119. So if I have to write this write-up, for a descriptive cross-sectional study design using sample size calculation formula for, this is a proportion type of data. You can also call it as qualitative data. And we have to write the source of formula. In this case, it is the website, OpenAP website. At 95% confidence level, it was already quoted in that window, and absolute precision of 5%. We have taken it as a 5%. I've written here that it should be less than the proportion and also less than 20%. For a proportion of 10%, here I will quote your reference article. For example, Dr. Saili et al. So that 10% I took from some published literature, that is not my figure. The estimated sample size is 109. Assuming 10% non-response rate, the final estimated sample size is 119. And in present study, total 120 or 125 or 130 subjects will be enrolled. Based on your study duration, you can always round off to the nearest possible value. And also, how they will be enrolled, is written. Is it visible actually?
Yes, yes, sir.
So the subjects will be enrolled using simple random sampling or using stratified random sampling or systematic random sampling. So that line also has to be there. This is how usually the write-up is expected in protocols or even in final thesis or research paper when you submit. So sample size and sampling method changes as the study design changes. So for case control study, for cohort study, we have, if you go back to that option of OpenAP, we will find that there are different options available. So this is for case control study. This is for cohort study. And this is when we have a quantitative variable, then only we use the mean difference formula. That is again either one of these study only. Now you might wonder, there is no analytical cross-sectional study ka sample size calculation in this. So if you check this, this is a sample size calculation not only for cohort, but also cross-sectional. So this is analytical cross-sectional sample size calculation, also cohort as well as RCT. So three options in one tab. So your most of the study designs ka sample size can be easily calculated, provided we know what has to be fed in where. So if there is a time limit, if there is a chance, again, I will like to do this hands-on with everybody, and you can come up with your cohort or case control or different kind of designs, get the information what is required for that, and we can actually calculate the sample size using this particular platform. So based on different designs, the sample size calculation option changes. Although in this particular presentation so far, I haven't discussed the study designs which validate diagnostic techniques with a reference or gold standard techniques, where the sample size calculation is based on sensitivity, specificity, and incidence of the disease for which the diagnostic test is being researched. if there are multiple variables, as usually in our most of the psychiatry or medicine disciplines, we have multiple variables, then the sample size calculation shall be based on most priority variable of interest. And if you can't decide the most priority variable, then calculate the sample size for each of the variable, and whichever gives you maximum sample size, follow that, because it will cover for all other variables too. Also, sample size calculation is must for all quantitative research for external validity of the study. Otherwise, the study findings are limited to your own study. In qualitative studies, sample size calculation is not required, as Mehta madam has already told us. However, their sampling methods are very unique. Like you have to have cases which are typical, also cases which are atypical on either extremes. But in this particular presentation, I haven't discussed the variants of different quantitative study designs, like types of case control studies, as somebody has asked the question of nested case control study. The type of course studies, yes, there are retrospective, ambispective, there are different course study designs as well. Also, I haven't discussed the types of RCT in detail, considering the time limit. I haven't discussed the quasi-experimental study designs either, and qualitative study designs also I haven't discussed. Mixed method designs where we combine qualitative and quantitative studies also I haven't discussed. Sampling methods I would love to elaborate, but usually there's a tendency to take samples which are easily available and convenient to us, and that will jeopardize the finding of your research. There has to be a robust mechanism to select the study subject which are being enrolled in your study by either at least simple random sampling or systematic random sampling. And on that day, you or your colleague or somebody has to be present when that number of that allotted number patient turns up. That should be enrolled with proper IPC. So that was only one sample size calculation I demonstrated. If there are queries and if there are interest, and if there is a time, you can ask for other designs too.
Yeah, that
Kindly.
was a very good presentation, and I think we can ask some questions, Ali, if they're there.
Oh, ma'am. I request all the attendees to kindly put their questions in the chat box. One of the question is, could we have your
Shall I stop
So
sharing
I
the
think you will get the queries for sample size calculation, Dr. Patil.
I think we can, Neena, we can have something like a helpline,
Yes.
like, you know, so all the PGs will start putting the queries and we can help them out. Because that's what happens. So when they have to submit, then only they realize that now what to do, you know.
And I have also realized that in all the sample size calculation, we have never put the non-responder rate, whatever, because we have tried to see that the sample size comes to as a something which is feasible, because none of
Oh,
these people have the time to do it.
yes.
Yes,
So
there are possibilities of making it feasible by changing that absolute precision now in this
yeah,
case,
right.
or by finding the reference which gives you lesser sample size. I
Yeah,
believe
that
so.
all those tactics we all
Yes,
tried.
yes. And
Yes.
we do suggest that to the student at times, because it is really
Yeah.
difficult for them to complete the study otherwise.
True, true.
Yeah.
The recording is available on the IPS WZB website. So I would request all of you to please subscribe to our YouTube channel, and all this session will also be put up by tomorrow. I think there were some questions about recording,
yes,
but an
yes,
excellent
ma'am.
session, Dr. Patil. Yes.
I hope I could help. I could be of some help in this small
No,
interaction.
definitely, it was really good and it was very lucid, clear, and specific, and quite to the point, and very basic things you have addressed. If that itself, the PGs understand, that itself is a great thing, then they can build up later on other things. Yes.
Thank you.
Yes. Um, one of the question by Dr. Mohita Joshi is how allocation concealment is done, sir.
So yes, there are softwares for that as well. Random allocation by simple technique, what we used to follow is a lottery method. They pick up one sheet and they go in that group kind of. So that is allocation is either by simple physical lottery methods, or there could be a computer generated random numbers or randomization techniques. Concealment is something really, I don't know, in psychiatric context, I never discussed that, but yes, concealment is possible provided you brief to the patients, especially in drug treatments, how exactly the packaging of drugs is done, what kind of color the drugs have, the placebo as well as the newer drug as well as the older drug, so that even the researcher as well as the patient as well as the data analyzer is not aware about. Only maybe another psychiatrist, another person who is supervising the treatment is aware, but the researcher is not aware. Even in anesthetic setups for those life-saving drugs or those very life-threatening drugs do follow concealment. So somebody is aware, but you are not aware. Somebody who is responsible and eligible is aware. So that's the way, but I have never thought about concealment in psychiatric treatment as such.
But very difficult, because if we talk about drugs and all ADR, it is so visible, in the next follow-up itself or in the assessment, and then it becomes very difficult. Most of it is, psychiatry, very difficult. But for PGs, I would recommend that don't go for RCTs as such. It is a team effort as such, so do some more basic but more study, more scientific baseline research.
Any more queries, Dr. Simon?
Yes, sir. There was one question: how to calculate sample size in interventional studies?
So, like I said, that single option is available in OpenAP, where for cohort design, the tab is there where we can select that tab and feed the necessary information. For example, the RCT, what we were doing in that research question, we enrolled the expectant mothers. We had subjected them into two different modality groups. One was IPT, another was the usual treatment option. And then we followed them whether they developed the postpartum psychosis or not. Now, if some researcher has done similar study, you'll find that how much is the difference in the proportion of postpartum psychosis in these two treatment modality groups. And he might have published it. So we'll need those two proportions, and there is an option to feed in those proportion details in the tab which is there on OpenAI. So if we give the necessary information, we can, the way I fed the proportion and other details, and I could get the sample size for a descriptive cross-sectional study. Similarly, we can get it for the RCT. Only concern comes, what if the outcome variable is not proportional? Suppose it is some scale-based score where you are getting the score and it is not having any category as such. Higher the score, higher is the chance, lower the score, lower is the chance. Those kind of scales are there mostly in psychiatry, where there is no clear-cut cutoffs being given in certain scales. So we took mean of those scales. So in that case, the mean difference is the option available where we can use the sample size calculation. So based on the study design, based on the information of that variable which is interest for us, and that information has to be from a published article preferably. Only question will arise, what if there is no published article, it's a novel study? Yes, it is possible. Or even if there is a published article, that information is not accessible. It might be a paid journal, or there is no clarity, or the setting is completely different. It is not similar to your study. So in that case, pilot study is one of the options where you have to prototype enroll few subjects. But again, how feasible to do the pilot is itself a question. And if you go by consort or the STOPS guideline for these observational studies, consort is for RCT studies, they say that even for pilot study, you're supposed to calculate the sample size. So it's really become difficult at times if some journals are asking how you will calculate the sample size when there is no reference available. So our suggestion to all the budding researcher is when there is no authentic reference available, a close by reference will do. Maybe the study is not in the similar setting, maybe the study is not in the similar patients, but close by range of patients. Because you may not be able to get the exact reference as it is most of the times. It is possible that the actual reference is not up.
Okay. Okay. Thank you, sir. I don't think there are any more questions coming.
You want me to
Uh,
demonstrate the city per sample size? It will be too much otherwise.
Can we
I don't know. I'm
ask
asking.
the seniors?
Do we have time? The slot has a time, and if
I think
people want, yeah,
1 hour
please
is
go
over,
ahead.
Yeah.
but it's fine.
Okay. Thank you, sir. Dr. Ritambara Mehta, ma'am, can I have
Yeah.
your remarks on the session, please?
Yeah,
If you
I
could.
mean, it was a very good session. I did already, I think I gave the remarks, but again, it was very good, Dr. Patil. Thank you for giving such a lucid and, as I said, very clear to the point with examples. It was the best thing to do, and you have actually. Done both the things, that what is your research design, and so what should be your sample size, and that was a very almost hands-on kind of a session. People could understand it, and very excellent. Thank you. Thank you very much.
Thank you.
Thanks for the
Thank you, ma'am.
opportunity.
Thank you, sir. I think I'll conclude the session now.
Yes.
Yes. I thank Dr. Deepak Patil, sir, for his expertise and insights regarding the subject. We have very well understood how to go ahead with our studies and study design. Very easy way to calculate our sample size, and the app open